Hello, everyone. There we go. I think we're going to start now. So welcome to this first session. My name is Elle Wadsworth, and I'm a senior analyst at RAND Europe, as well as a research fellow at the University of Bath, and I'll be chairing this first session. So my work primarily focuses on cannabis legalization in Canada and the US, so jurisdictions that have undergone many changes with regards to cannabis policy in the past decade, giving researchers, policymakers, and other stakeholders much to observe and learn from, particularly in jurisdictions outside of Canada and the US that have made or are making, potentially looking to make changes to their own cannabis policies, including here in Europe. It therefore gives me great pleasure to be chairing this session titled Cannabis Legalization in Canada and the US, Policy Variation, State of the Evidence, and Ideas for Future Research. We've got a stacked cast today of 5 fantastic speakers covering the Canadian and the US perspective, highlighting insights from the legislative review on the Cannabis Acts in Canada, as well as the recently published report from the National Academies of Science, Engineering and Medicine, NASEM, on the report of Cannabis Policy Impacts, Public Health and Health Equity. So of our 5 speakers, we have François Gagnon from the Canadian Centre on Substance Use and Addiction, and Hanan Abramovici from Health Canada, who will give us our Canadian perspective. We have Beau Kilmer from RAND Drug Policy Research Centre, Rosalie Pacula from the University of Southern California, and Susan Weiss from the National Institutes of Drug Abuse, who give us the US perspective. So I will introduce our first speaker, who is François Gagnon. He's a senior scientist and senior policy advisor at the Canadian Centre on Substance Use and Addiction. He was previously a scientific advisor at the National Public Health Institute of Quebec for 17 years, specializing in public policy. François is a distinguished member of the French Monitoring Centre for Drug and Drug Addiction and serves on the editorial board of the journal Drugs, Santé et Société. François, welcome.
Well, hi, thank you for coming to this session. I hope it's informative. I have the pressure of being the first one, so first impressions leave kind of an impression, I guess. So thank you to Rosalie somewhat and Beau for inviting me. I'm not sure I'm up to the par of presenting what's going on in Canada in 15 minutes, but I'll try to my best, especially in French. It would have been nicer, but English is going to be my language for today, right? So, I hope the slides work at some point. Yep, okay. So, quick presentation plan. I'm going to go over public health outcomes for today and cover very rapidly outcomes in monitoring and research. Regulatory developments is going to be the second thought, and I'm going to leave a few final thoughts afterwards for discussion. Just before I go on to the details of what's going on in Canada, I just want to remind the people who know the situation in Canada that we're a federal state and that we have a complex relationship between the federal and provincial governments. The best way to talk about it is maybe to look at this graph that many of you might know and that outlines the basic idea that if you move from prohibition to very lax commercial regulation, it would include quite some level of arms if we consider what's happened in tobacco in the past years, and if we consider what's going on in alcohol in some respect in Canada. I think you see the needle moving right towards more harms. So what's been happening in Canada, I guess, from the federal perspective, the law has been set up so that there are some things that are regulated at federal scale and some at the provincial level. I'm going to try to describe these things with regards to this framework or this graph, that, the U-shaped form that you see. So at the federal scale, we generally see that production has been regulated at the federal scale. So the type of products that are authorized the price. There's an excise tax on the production that's put there. At the federal level also is a promotion regulation. So the promotion regulation generally in Canada authorizes informative promotion, but not incentivizing promotion. But the law was also allowed the provincial governments and territorial governments to set up their own distribution system. So, for example, all the retail systems are provincial or territorial in Canada. And also regulate the possession. There are some rules around possession and places where people can use, which are at the provincial scale. Right? So, I guess at the federal level, if we refer to a U-shape, if we think about the excise tax or the promotion, you would be situated quite in the middle of it, because you kind of think that, you know, you want to give access. Maybe in a public health framework, you would want to give access to people, but not promote use. And also the excise tax keeps some measure the price of consumption of products relatively high, so that price does not become an incentive to use. In some other aspects, though, it might be like the diversity of products that have been regulated. If you compare to Uruguay, which is only allowed the dried products, or if you compare to what's going on in Switzerland, which is with the pilot project, which has limited to 20% the THC. So you might see the federal scale like a bit right of the public health framework, moving a bit towards the legalized with few restrictions on the scale. But generally, you could say it's really a public health framework that's been adopted. The provincial scale, there's much diversity, and maybe the one outstanding province that's been set up as a not-for-profit orientation is Quebec, my home province. But other systems, like provincial systems, more relaxed in the way they promote. For example, in Quebec, there's been a limitation of THC content at 30%, a relative 30%. There's been a limitation of edibles. We don't sell chocolates in Quebec. We don't sell desserts, pastries, these types of things, which are sold in the other provinces. So there are provincial variations, and so they move the needle right or left. They bring it back a bit left in the case of Quebec, I guess it's fair to say. So that's basically the background of what's going on in Canada. So use in the past year, I put there the four most populous provinces, and I didn't include the Canadian average, but if you looked at it, it would show something like the higher average. So if you look closely, you will see that it's increased somewhat differently across the provinces, a bit less in Quebec, more in the three other provinces. So 85% of the population is represented there. If you think another indicator or measure that's often used in public health is daily and quasi-daily use, and again, there's a bit of difference between the provinces there. In terms of, a counter argument to all the regulations that have been put in Quebec and the more stricter regulations that generally can be thought of is that it will divert people to the clandestine markets. But if you look at this set of data by David Hanan and the International Cannabis Policy Study, you will see that all the provinces are around now 80% of the share of products sold. So in general, these are monitoring data, like surveys. There are more surveys. There are probably around 10 surveys that look at cannabis in different ways, either at the federal scale or in provinces. I'm not going to go through all of them, but these types of data are seen also in the studies that are performed on cannabis use, like the scientific articles or in other documents that are produced by various authorities. And also, if you look at the health outcomes that are monitored, the admissions to emergency rooms or admissions to hospitals in general, if you look at the trends in data for road collision, trauma related to road collisions. There lots of measures are made, and they kind of tend to align with the tendencies that we see there. Though there's a lot of measures that are studies that show no change, but when there are significant changes, they tend to be more in the upper side. Some are lowering, reducing, like in some aspects. For example, in cannabis use in youth, you will see a reduction generally in the surveys that we have and in the research that we have. And in some specific populations too, in higher consumption people, some reductions in some studies you will see. We have also studies in terms of determinants of these patterns of consumption and risks and harms. There's been many studies around the promotional activities, and they show generally that the law is respected, though there are they show that to some level there are some incentivizing promotion going on, but I'll get to how this has been addressed thus far. A few studies on prices, on places, on the business environment, how many stores there are, where they're located. They tend to show, for example, that there are concentration in low-income neighborhoods. There's not much studies, though, and now I'm getting into gaps. I'm advancing on myself, but there's not much study on governance mechanisms. There's also a few studies, not that very much. One that was produced, a report that was produced by CCSA that showed a large reduction in penal sanctions for people using or possessing cannabis, and a few others that I've tried to see differences in socioeconomic status and also by racial or ethnic groups. They tend to show that there's been a large reduction generally, but there's still, in some cases, differences in ethnic groups. For example, I think black people, that's how it's termed. I think in the study, black people tend to be a bit over-arrested or over-sanctioned in penal terms. But you can look at the study yourself. I've put it there. There's also been a few provincial comparisons, maybe not as much as maybe it could have been, but there's been a few cases. Some have compared Ontario and Alberta, for example, but most have centered on the difference between Quebec and others. When they've looked at Quebec and others, they tend to show less bad results or less increases in harms. So getting to gaps, I'm sorry, I'm trying to be mindful of time. I'm not sure how this is going, but I don't see the time, 5 minutes? All right. So in terms of gaps, I guess my colleagues are going to go on into some more details tomorrow. That's a publicity or a promotion for the activities of my colleagues that are going to be talking in more details about these things tomorrow afternoon. But in terms of provincial studies, like most studies I've concentrated on the 4 provinces that I've shown you. There's still some way to go to analyze what's going on in smaller provinces, such as the Prairie provinces, Alberta, Manitoba, and the Maritimes. There's not been much study by researchers there. And also in terms of provincial comparisons, I think there needs to be more. There are more details that can be delved out and try to look at different results between the provinces, because many have implemented different regulations. Just think of one large preoccupation we have is the higher THC content. In BC, there's been a tax that's been applied to vaping products with high THC content. In Quebec, they're not sold. In one province, I forget the name, in the Maritimes, they've only allowed sales of products that don't have flavors added, or so there are differences among the provinces, and maybe research studies could be made on the variations and could be used to inform future policy decisions. Of course, the biggest gap is that our studies, like in terms of harms and risks, are limited to 2021 and 2022, even though we have studies coming out in 2024. The data that they use go up until 2021 only. 2022, I think I've seen a few lately. So there's a lag between the time that the researchers do the studies and publish them and the time that we are at present. So we have relatively limited time to assess legalization. In next years, we hope that there's going to be more. And of course, keeping in mind for public health, most of the harms that we think that will be induced by legalization is going to be long-term. If you think about tobacco or alcohol, it's something like 75% of the harms that are due to long-term consumption, and there are, I think, reasonable assumptions to be made as to the changes in consumption behaviors, whether in terms of products or careers of consumption that in cannabis tended to stop at the passing of adult age. So longer-term look is going to be needed, and we hope researchers are going to be there. Regulatory developments, there's at the federal level, there's been a review that was legislated. It was mandated in the Cannabis Act itself, and the report, these were large consultations with most of the researchers that are involved in cannabis policy or issues in Canada, and even with the provincial, 1 minute? Oh, I'm sorry, I'm gonna have to go very fast. I'm going to choose some of the things that I was supposed to say. One of the things that I should note is that coming out of this report by the legislative review was that there was some confusion on what exactly meant by informative and incentivizing promotion. And Health Canada recently, like in January 2024, clarified that, for example, temporary rebates were incentivizing because there was this notion that we could see those kind of ads, like rebates of 25% buying these type of things. So Health Canada clarified that these type of things were not authorized. As well, Health Canada also clarified the temporary rebates. Also on the websites, promotions on websites is authorized, but the law says that there's going to be a reasonable mechanism to block access by youth, and also the clarification by Health Canada stated that what was implemented at that point by cannabis operators was maybe not sufficient. There's also a regulation coming up, and most of these the proposed regulations are meant to reduce industry's burden, administrative burden, and most seem, from the point of view of public health at least, from what we looked at it, were quite benign or not really, meant to I'm going to finish very fast. So they were not supposed to, we didn't think they would increase consumption or risk, but we had some questions around relaxing the limits on edible packages, also on the promotion expenses reporting. The companies will have to do reports internally, but they won't have to report it to Health Canada at this point. In the future, if the regulations goes through, and we thought that it could have been an occasion to put in a standard THC unit. I'm going to go on in the provincial sphere. I think the provinces are mostly, navigating this this idea of not increasing consumption too much, and in some cases trying to protect public health, and at the same time not also favoring the industry in some reasons. So in Canada, I think it's fair to say that at the first scale there's public health orientation and protection. Health Canada is in charge of monitoring the promotions and enforcing the laws in many respects. So that's a good governance tool, and it's been responsive in many ways to the recommendations of public health people. But we're navigating this space both at the federal scale and provincial scales. I encourage you, because I know a lot of researchers are here in the room, to continue monitoring middle ground options, like between largely liberal commercialization that we see in many jurisdictions and more conservative one that we see in Canada and Quebec, especially in Canada. I'm going to leave it to that. I think I'm a bit over. Right?
Thank you, Francois. I'd like to now invite up Beau Kilmer. So Beau Kilmer is the co-director of RAND Drug Policy Research Center and vice president of the International Society for the Study of Drug Policy, the ISSDP. Beau's publications have appeared in top journals, including the New England Journal of Medicine, Proceedings of the National Academy of Sciences, and Science. And 2 editions of his co-authored book on cannabis legalization were published by Oxford University Press. Beau, the floor is yours.
Good morning. It's so nice to see so many members of the International Society for the Study of Drug Policy here in the audience. For those of you who aren't members, or maybe if you're ISSDP curious, we're co-sponsoring a number of the panels throughout the conference. So I hope you'll enjoy the panels and maybe even think about joining the society. A couple years, or actually about a year and a half ago. All right, we got the slides. Yep. So about a year and a half ago, Rosalie and I were honored and privileged to join the National Academy of Sciences, Engineering, and Medicine, their committee on the public health consequences of the changing cannabis policy landscape. And about a month ago, we just released our final report. And I have to say this very much was a group effort. There were a number of other researchers and an amazing staff. But the statement of task, what we were asked to do, was to describe the cannabis and cannabinoid availability in the United States, assess regulatory frameworks for the cannabis industry focusing on social equity, identifying the strengths and weaknesses of public health surveillance systems within the United States, recommend a harm reduction approach to cannabis policy, and set a policy research agenda for the next 5 years. I want to make it clear we were not asked to make decisions about legalization, federal scheduling, or prohibition, and we also did not comprehensively review the health effects of consuming cannabis. So as you can imagine, this is a large report, and there are about 5 topical chapters. So chapter 2 focuses kind of an overview of cannabis policy, mostly on the United States, but we also do spend some time talking about what's been happening in Canada as well as in Uruguay. The 3rd chapter focuses on cannabis consumption and markets in the United States. Chapter 4 applies core public health functions to cannabis policy. And Chapter 5 focuses on how cannabis policy influences social and health equity. And then we have a final chapter which talks about the available and needed research on cannabis policy. So for the next 7 or 8 minutes or so, I'm going to talk about some of the highlights from Chapters 2 and 3, and then Rosalie is going to come up and talk about some of the highlights from Chapters 4 and 5. As many of you know now, more than 75% of US states have either implemented adult use legalization or medical cannabis legalization. In fact, more than half of the US population now lives in states that have passed laws allowing for adult use and production. However, cannabis still remains illegal under federal law. And as many of you may remember, when Colorado and Washington passed legalization in 2012, no one was quite sure what the federal government was going to do. And it wasn't until later in 2013 that the US Department of Justice released a memo, basically saying, hey, look, this is all illegal under federal law. But as long as you follow certain guidelines, we won't make it a high priority to enforce these laws in states that have legalized. But what that essentially meant is that the federal government largely just sat on the sidelines and watched the industry grow in a number of states. Even when President Trump came in and Attorney General Sessions rescinded that memo, for all intents and purposes, nothing really changed. And so while you have all of that happening, there also has been a massive proliferation in intoxicating hemp products like Delta-8 THC, which are now available in many states that have not legalized, as well as some that have legalized. And as I said, this 2018 Farm Bill that passed by Congress, it really changed the cannabinoid landscape. And it was something that not a lot of people saw coming. Essentially what this Farm Bill did is a lot more technical, but it removed hemp from the Controlled Substances Act, making it legal to cultivate and sell cannabis products with less than or equal to 0.3% delta-9 THC in terms of dry weight. But what this meant is that it facilitated the growth of a new industry that includes intoxicating products derived from cannabis legally classified as hemp. So you can produce, you have the industrial hemp, you get all the CBD out of it, then you synthesize that into delta-8, you can synthesize it into delta-9, and all these other cannabinoids. And so with this really broad definition, it's created these legal uncertainties and inconsistencies across the states. Some states are trying to ban them, some states allow them to be sold, but the availability of these intoxicating and unregulated hemp products, it raises real concerns about the potential health risks of using these substances. Now, within the states, there's a tremendous amount of variation in terms of their approaches to the supply chain, whether it be respect to regulations on cultivation, manufacturing, marketing and sales, and even on possession and quantity limits. And this is important because when you see so much of the research that focuses on legalization, they still use this binary measure. Did the state legalize or not? But Rosalie found, she did research 10 years ago, looking at the medical cannabis laws in the United States, finding that when you use these binary measures, as opposed to focusing on the specifics of the state laws, you get very different inferences about some of the health consequences. And indeed, even though there's been a lot of variation in terms of what the states have been doing, there's been inadequate attention to lessons from alcohol and tobacco policies. For example, there hasn't been much discussion about state monopoly models in the US. There's been almost no discussion about using minimum unit pricing. Alternative approaches to taxation, there are a few states that have implemented potency-based taxes, but that really hasn't been part of the conversation. And also in terms of alternative regulations for marketing and sales, such as plain packaging. So in terms of the conclusions from this particular chapter, the first one was that the redefinition of hemp in the 2018 Farm Bill has led to uncertainty about the legality of cannabis products and the emergence of a new market. So the group decided and recommended that Congress should close these legal loopholes leading to the unregulated sales of intoxicating hemp products. The second conclusion from this chapter is that the federal government has not provided adequate guidance on public health policies for cannabis legalization, leading to inconsistent state regulations. And that's the thing, even if the federal government keeps it illegal, it still can play a role in terms of providing guidance to the states, and it just hasn't been doing that. The third conclusion is that other countries have adopted a centralized, government-regulated approach that much more focuses on public health than what you see in the United States. So the main recommendation here was that our Centers for Disease Control and Prevention should conduct research and develop best practices for protecting public health in these legal states. We do, as I said, regardless of what happens in terms of if it's legal or not under federal law, the federal government and the different agencies can still play an important role in protecting public health. Similarly, we argue that state-focused associations, such as the National Governors Association, should begin to develop model legalization for these states that have decided to consider these alternatives to prohibiting cannabis supply for adult use. As I mentioned, Chapter 3 focuses a lot more on consumption in the markets. And there's a tremendous amount of data. In fact, we had to move a bunch of it to an appendix. But in terms of perceived availability, it obviously has increased since 2014, especially amongst older adults. However, it actually, perceived availability did decrease amongst youth aged 12 to 17. In terms of prevalence, we definitely have seen a big increase in past month and past year, but also if you look at that red line, that's the change in the number of people who use on a daily or near daily basis. This really has exploded over the past, not since 2014, it really has exploded over the past 20 years. And in fact, many of you have seen this chart. John Calkins just published this in Addiction a couple months ago, showing that in 2022, for the first time in the United States, you had more people using cannabis on a daily or near daily basis compared to alcohol. So it is becoming much more common in the United States. And it's not just people who are smoking flower. I mean, the products are changing quite a bit. We're seeing a lot more with respect to the concentrates, vape pens, edibles, and different ways of administering different types of cannabinoids. And we also see that there has been, and François alluded to this as well, there has been a big increase in the potency of these products. If you look at right around 1999, 2000, if you looked at the flower, the cannabis flower that the DEA was seizing, on average it was about 5% delta-9 THC. You go into some of the stores now, It's hard to find products that are less than 20% THC, just the flower products. Now, that doesn't mean you can't find them, but most of the places are selling products that are 25, 26, 27% THC, and that's just with the flower. Obviously, with some of the concentrates, the solid concentrates, definitely most of them are above 60% THC. Some of them may actually have levels above 90%. So we've seen this massive increase in kind of the potency of the product. And in terms of findings on the markets, we had Dave Hammond, who'd done a lot of work, who created the ICPS, and we had him do some runs specifically for the United States. And so these weren't published in the journal, they were published in the report, just showing that, between 2018 and 2023, look, there has been an increase in purchases from stores. It went from about 26% in 2018 to over 50% by 2023. And we also found that, look, purchases from dealers are declining, but they still even occur in legal states. This is an important lesson. It takes time to significantly reduce the size of the illegal market. But we also know that illegal production still occurs, and even in states that have legalized. And this is important because we're also noting that prices are really continuing to decline. And this is matters for a lot of the outcomes that get discussed in legalization debates, whether it be consumption, size of the illegal market, what happens to tax revenues, the profitability of businesses, which has implications for social equity. All of this is really much a function of price. Now, with legalization, you're definitely going to push down those production and distribution costs, but that doesn't necessarily mean that the retail prices have to fall. As I said, depending on how you tax it, if you implement some type of minimum unit pricing, you can keep those retail prices higher if you want to. That's not the path the United States has taken. In fact, we've seen this large decline, and we show a number of examples of this in the report. And this is just looking at in Oregon, the median price for a gram of flour was, in 2017, it was above $10 and today it's now less than $4 a gram. And we've seen other declines in other states as well. And so in terms of the conclusions for this chapter, because you have this increase in the potency, and then you also have the decrease in the price, it actually means that the price per unit of THC is actually dropping faster. And obviously, this, as I said, this has implications for what happens to consumption, what happens to the profitability of businesses, which, like I said, has important implications when we start talking about social and health equity. And obviously, the reduction in the size of the legal market depends on a number of factors, including regulation and enforcement. And Elle, how much time do I have? 0. Okay, I'll end with one final comment. So, after these states pass legalization, it often can take up to 2 years where you spend a lot of time trying to create this regulatory system, getting licenses, allowing stores, doing inspections. What typically doesn't happen is that there isn't much of a focus on what are you going to do about the illegal market, because it's a choice. In fact, you can imagine a scenario where you spend more money on cannabis enforcement after legalization than you do beforehand. But that's not the pathway that the United States has taken. And I want to make it clear when we talk about enforcement, it's not just about applying criminal penalties. You have other civil penalties as well, going after landlords. There's a lot of things that you could do to try to reduce the size of the illegal market and try to move people over. However, that just hasn't been a priority in most of the states that have legalized. With that, I'll turn it over to Rosalie. Well, she'll get introduced, and then she'll talk about chapters 4 and 5. Thank you.
Thank you, Beau. I'll now introduce Rosalie Pacula. Rosalie holds the Elizabeth Garrett Chair in Health Policy, Economics, and Law in the Health Policy and Management Department at the University of Southern California's Price School of Public Policy, and is also a senior fellow at the USC Schaefer Center for Health Policy and Economics. Outside of the university, Rosalie serves as the co-chair on the National Academy of Sciences, Engineering, and Medicine's Forum on Mental Health and Substance Use Disorders, and was a committee participant on the NASEM report that we will be hearing more about right now.
Thank you, Elle. So this is such a mammoth book. It took 2 of us to cover, and I do apologize to Francois that he didn't get the team shot that we do. But as Beau already mentioned, in Chapter 4 of the NASEM report, we really focused on the extent to which states in jurisdictions in the United States are implementing a public health approach to their cannabis legalization policies. But we had to define what we meant by that. And so we fell back on a framework, the Essential Public Health Services framework that's been used in the United States for the past 25 years to kind of define the mission of public health agencies and their services. And this framework was modified in 2020 to incorporate these 10 essential services that are required for the public health mission that fall into 3 broad categories: assessment, policy development, and assurances. In terms of assessment, the major 2 activities are basically to assess and monitor the population's health and factors that contribute to the health within communities. Secondly, there's the goal to investigate, diagnose, and address health hazards and the root causes of health problems within communities. And this is just kind of the overall what's happening with surveillance. Then in the area of policy development, there's really this push in public health services to try to communicate both the state of the knowledge and informing consumers as well as educating the public on both public health benefits and harms associated with a product or initiative. There's the second goal of strengthening support and mobilizing communities to engage in improvements in public health education and infrastructure. Third, there's creating and championing and then implementing policies, plans, and laws that aim at improving health or the infrastructure that's needed to improve health. And then finally, even if those laws get passed, you need to utilize legal and other regulatory frameworks to tweak them as you learn the implications of these laws on public health overall. That's in the area of policy development, and then you move into assurance. Assurance is as important as the other 2 areas. They enable and ensure equitable access to healthcare services and needed care throughout the community, regardless of what the general policy is. You can think of this applying to tobacco, sugary drinks, any of these products. Secondly, building on a diverse and much-needed skilled workforce to keep moving the infrastructure and the services forward within the community. Improving and innovating through evaluation, research, and quality improvements, the healthcare services and the infrastructure, and then finally building and maintaining the needed services and infrastructure to obtain the public health goals. So this is the broad framework that we use to evaluate state cannabis policies in the US. And I just clicked us out of there. There we go. I'm going to go this way to get us forward. My apologies. So in thinking about application of cannabis policy and its use of these core public health functions, in all 3 aspects, whether you're talking about assessment or policy developments or even assurances, most of the state policies achieved some elements that fell short in many. In the case of assurances, most states lacked a comprehensive surveillance system to adequately monitor all the implications of legalization, largely due to inadequate funding, because this is an activity that is generally done with the federal partner, and there was no federal partner engaged in these activities, at least as it was pertaining to the legalized market. In terms of policy development, there was a whole bunch of development related to the initial formalization of these markets and establishing rules for the markets, but public health agencies were less engaged in most of the state laws, and so there's limited consideration for some of those public health objectives that could also be achieved with the legal market. And unfortunately, in many of the US states, because there was a perception of cannabis just being a harmless plant without foresight of potential innovation of the product into a bunch of alternative goods, industry, which was welcome to the table in terms of setting up regulations for setting up the market, also played a pretty important role in blocking some subsequent public health initiatives to try to modify the market after it was legalized. Because it hurt profits. In the case of assurances, states were very good at doing some testing and setting up state seed-to-sale systems where they could track what's happening to the product, which is one element of assurance. But the problem is that states didn't do it consistently. It's not uniform. A product purchased in one state does not guarantee that you'll get a very similar product in another state. And there's many other aspects of assurance from a public health perspective that we mentioned that haven't been yet addressed by the states. So our conclusions when we looked at the utilization of a public health framework for the state cannabis legalization is that so far in the US, there's just been an inadequate inclusion of public health objectives and the application of the core public health functions in legalized states. What we recommend is that the Centers for Disease Control and Prevention work with other federal partners to try to develop a more comprehensive surveillance system, getting at that first broad goal of public health that has more components of public health built in and less just about market measurement. Our second recommendation, the US Pharmacopoeia is already working on establishing product quality and analytic standards for cannabis flower and as well as the extracts that get used and infused into edibles as well as pills. And so our recommendation is that state cannabis regulators immediately adopt and enforce those standards as they come to fruition and get standardized so that a product that it gets purchased in California or in Massachusetts is very similar in terms of the standards. A consumer would know it's more or less the same product with the same ingredients as someone in Colorado, for example. Another conclusion is that the industry lobbying in the United States and their conflict of interest has interfered with the ability to adopt many important public health regulations at the state levels because they've been downplaying the risks and overselling the benefits of the healthcare marketplace or of the cannabis marketplace. So our recommendations, because again, as Beau said, we had to assume the world as it is in the United States without federal legalization. We couldn't speak on that. So our objective was to encourage state cannabis regulators to require training and certification of staff in dispensaries who interact with consumers, to get educated by outside vendors on particular topics, not industry. Many states actually have industry training of retailers in US states. And so this way we can make sure that the main contact that consumers are getting most of their information from, the dispensary workers, have information on the effects of cannabis on humans more generally, information on how to prevent sales to minors, warnings about impaired driving, the risks of using while pregnant, and importantly, that they are trained to understand naive users shouldn't be channeled into the higher concentration products, that can impose risks, and how the retailer, retailer employer can understand impairment. Most states have host liability laws for alcohol. A retailer can actually get sued if they sell to someone who's already impaired. The thinking behind this is to adopt the same sort of philosophy, training the person who's selling cannabis to be aware of level of impairment from cannabis and not overselling if the person is already beyond a given level of impairment. Obviously, we have to measure that. That's going to be a challenge. So the next recommendation relates to federal public health agencies and their knowledge, because there is a lot of knowledge in the federal government, even if it's not legalized, to develop educational campaigns about the potential risk of cannabis and send this out to the states so it can be used in developing these education strategies. Now in the US, we do have guidelines that get used for screening adults for use that are in the healthcare system, as well as how to train clinicians. Because the US healthcare system is a fragmented system, there's no federal recommendation that we can make, but the idea was just to remind people that these are available within the states and they could be used. I'm limited on time. I'm going to go quickly through the social and health equity concepts. And what we mean here for health equity is that everyone has an equal opportunity to achieve their full health potential. For social equity, we're referring to valuing everybody equally in a way that the community has ongoing efforts to ensure that inequalities and injustices are adequately addressed. And when we looked at the cannabis policy impacts on social and health equity, we really saw three areas where it had significant associations: the criminal justice system, social equity programs, and social determinants of health. I'm going to touch on each of these very briefly, just saying in the case of criminal justice, even in the US, which generally has very rich data, our data on arrests are also very, very limited. You're seeing results from two different studies tracking white arrests and black arrests in the darker colors. Bottom line is that there is a decline in arrests overall in the US associated with legalization, about 20%. When you look at it in terms of actual million days of use, those arrests have even fallen significantly more, almost by 70%. But the differential between blacks and whites, while blacks are at a lower level, when you look at it in terms of relative to their population or use levels, they are disproportionately represented in these arrests, even with legalization. And this is a concern. In terms of social equity, three general areas. Again, criminal justice reform, removing the penalties associated with those arrests, assisting industry participants, and then reinvestment in communities that have been particularly damaged by the prohibition. In the case of the criminal justice reforms, most states are adopting reforms, but they're doing so in a passive way where the individual who's been harmed has to petition to change their prior arrest instead of the state automatically removing that. Those have implications on ongoing injustices. In terms of the industry participation, there's been lots of efforts to try to engage minority groups in the businesses, but as Beau already mentioned, with declining prices and level of competition in these industries, some of this work is actually not as beneficial as it's perceived to be because the profits are not as great as they used to be. There's other ways of considering social equity for minority-served candidates by having them work in adjacent industries instead of as a retail dispenser, and those adjacent industries in accounting, banking, drug testing will remain even if certain consolidation happens in the industry. And then with respect to community reinvestment programs, these are really dependent on the tax revenue that's generated in the legal market, and so are susceptible to other uses of those taxes, as well as declining tax revenue that may come as prices start to fall, because most taxes in US states are tied to price, not tied to potency. I've run out of time. I do want to just say, in terms of social determinants of health, here there's a lot of spillover effects. If I get a chance to talk about them more in depth, I will. With respect to economic stability, yes, there's jobs, but drug testing still occurs, even for cannabis, and that can influence the stability of some users if those laws related to drug testing aren't modified to exclude cannabis. Education, healthcare, neighborhood and built environments, there are competing forces. Some ways they have been improved, in other ways they have been harmed by legalization. And then we have not been able to assess the social and community context. So our general conclusions, and I will stop there, is that cannabis prohibition has still disproportionately impacted communities of colors, leading to lots of negative consequences that weren't necessarily expected. While generally arrest rates have decreased, racial inequalities persist, and so that our recommendation is that jurisdictions that move forward regularly gather and report data on the criminal enforcement of cannabis and pay attention to potential discriminatory practices. The states that provide record relief are not as good at reducing the harm from criminal justice, from racial disparities in the criminal justice system, and we encourage states to consider instead implementing things like expungement or sealed records proactively instead of requiring the consumer or the individual to have to proactively do something about it. Employee drug testing, as well as drug testing of pregnant women, still comes with significant prohibitions, even with legalizations, because these are areas of law that haven't been fully considered when thinking about legalizing markets. So we want to remind jurisdictions to think about how they want to deal with these uncertain issues, and increasing retail access through extra stores in certain neighborhoods, they tend to locate in the poorer areas and in minority neighborhoods. And the research is showing higher density outlets is actually associated with many negative consequences, including health events and ED visits and poisoning calls. And so the recommendation here is that state regulators should really evaluate and reconsider how they want to accomplish social equity and reduce social determinants of health in a more comprehensive way that considers some of the unintended consequences of the market and set up regulations that can try to reduce these. And I will stop there.
Okay, thank you, Rosalie. I'll now like to invite up Susan Weiss. So Susan is the Director, Division of Extramural Research at the National Institute on Drug Abuse, or NIDA, which oversees NIDA's extramural programs, operations planning, and transnational institutes of health initiatives, such as the Adolescent Brain Cognitive Development and Healthy Brain and Child Development Studies. Susan also serves as a Senior Science Advisor to the NIDA Director and Scientific Liaison to the NIH and other federal agencies. Susan?
Thank you. So I'm very pleased to be here to be kind of a discussant and a respondent to information that you just heard from Beau and Rosalie on the NASEM report. It was one that was supported by the CDC as well as NIH, mostly the CDC. And this was an incredibly difficult and complex task that we gave them. It was quite, I think the scope of it was much more than any of us even realized at the outset. The data were hard to come by, and I applaud them for bringing in community engagement, and they heard very passionate and strong statements from advocates on both sides, people who have been hurt by cannabis's harms to health, people who've lost their children, as well as those who have been hurt by prohibition and having legal records that virtually changed their entire lives. So this was a hard report to write, and I think the committee took a very thoughtful approach, and I also appreciate that they weren't trying to simplify what was clearly a very, very complicated issue. The report highlights a broad range of issues, and it does suggest an overall framework for moving forward, but ultimately it raises many more questions than answers, but I think that's clearly where we are at this point. I represent a research funding agency, and I also appreciate the report from that perspective, because we're often asked why we don't have these answers already. Cannabis has been around for a long time. Why don't we know all of the health benefits and harms? Why don't we understand what's happening in all of our states? And I think this report very clearly identifies why this is such a difficult and daunting task. And we're not done. The laws and regulations continue to change in the states, and the future of federal policy is uncertain. In the US, as you've heard, we've had an explosion of new products on the market, both in the regulated cannabis market and then in the unregulated hemp-based cannabinoid market, which Beau described, and that's really complicating the picture. But the advantage of discussing this here at an international meeting is the opportunity to learn from each other, and as you've heard, we also have representatives on this panel from Canada who's really serving as a model for us in many ways, and hopefully we will hear from others as well. So for me, a lot of the take-home messages that I thought were quite important, again, it comes back to sort of the complexity of the issue, and this includes the scientific complexity. It's always been difficult to study cannabis because it's a plant, and there are many different varieties of this plant, and we don't talk about it the same way when we're talking to different people. Some people use the term medical marijuana to mean products that are mostly cannabidiol. Some people use it to mean products that are mostly THC, but we all use words that have different meanings to each of us. We have problems in identifying exposure, in measuring exposure. And we also recognize that there's really vast potential of this plant for both medicinal use and adverse consequences, and it's difficult to do research on it. And then layered on top of this general scientific complexity are the social and political and economic and commercial influences that affect perceptions and that affect policy, and in turn, the outcomes that we're interested in. We've heard that state policies vary on a number of different measures, and they're being modified over time to sort of address some of the issues that have been raised. There's been an increasing focus in many of the state laws on equity, and as you heard from Rosalie, some of these suggestions are more difficult to implement or are not necessarily going to have the intended effects that are being hoped for. And this is something that we really need to be assessing, but it may be a bit too soon to really understand that. And as also Rosalie said, industry sits on many of the implementation panels in the states. Public health has been more reticent to get involved because of concerns about legalization, and that's not a great thing because industry's interests are not necessarily public health minded. We need more data on use. We know that the patterns are changing. You saw some of the evidence for that. Daily use is now exceeding alcohol daily use. And we're not measuring in many of our surveys with the type of granularity that we need to be measuring to really understand what the impact is. The products and routes of administration are changing. We have much higher potency products. The cost is going down. And we don't have enough information on these high potency products. And it's difficult to study the high potency products because of the fact that it's illegal on a federal level, and so our researchers aren't permitted to purchase products from these dispensaries and then use them in the studies. So some of them have found very clever ways around this to get at it, but we can't do some of the work that everybody is demanding that we do, which is to really get a much better understanding of what the impact of these high potency products are and what sorts of exposures people are having. And again, measurement is difficult, and Canada is working on developing a standard unit of measure, which we are very excited about. We've been trying to implement this in the US. We have required our researchers to use this in the kinds of studies that they can use it, but observational studies or epidemiological studies where you're asking people to report on what they're using are not going to give us the sort of reliable data that we need. The whole hemp products just throws a monkey wrench into everything. They are so widely available, they are completely unregulated. We don't really know what the health effects are, and they have the potential to overtake the legal market. And there's an industry now that has strong lobbying abilities, and and so any sorts of attempts to restrict the hemp industry through the Farm Bill are being fought everywhere that they can be, including attempts by states to make it illegal. And of course, we need better surveillance for all aspects of the industry, including the illicit market. So one of the important recommendations from the report is greater federal involvement, and this is really important in terms of standardizing product testing, standardizing what's in the products, what the marketing practices are, product labeling, and as you also heard, training for healthcare providers and those in retail outlets. As again, Rosalie said, training is coming from industry people, and we really need to get people who are public health minded to be doing the training. We do have knowledge about health effects and who is most at risk and what are some of the things to be concerned about, even if we're still missing a lot, and that training needs to be available and standardized. So what are we doing? We do support a lot of research on policy in states. We do try to look at changes in policy that happen, but they're changing so fast, and it's complicated. One of the other kinds of studies that we are supporting that we hope will also be influential are these large developmental studies, which was mentioned in my introduction. One of them is called ABCD. It's called the Adolescent Brain and Cognitive Development Study. It's a study of nearly 12,000 youth, starting at ages 9 and 10 and going into young adulthood. And we are looking at many factors that affect development, and part of the reason for starting this study had to do with the changes in the cannabis laws in the United States and wanting to better understand what that really does to development. We know that's a vulnerable time. So it involves looking at measures of brain activity, brain imaging, but it's a very, very well characterized group of study participants who we've looked at their screen time, their sleep, their life circumstances. This is done across 21 sites in the country, and what's important about it is that we make the data available to all researchers around the world and around the country, so that people can ask different kinds of questions and can start looking at the factors that affect development and whether or not some of the outcomes that we associate with cannabis are really because of cannabis exposure or because of other factors in their environment or because of some interactions or early use of other drugs. And really being able to sort of delineate some of these variables is something that we're hoping to do with this study, and we're hoping to use that information, again, to try to influence policy. And we're able to do that. We can even look at how the different policies in different communities may be affecting use and outcomes. But again, our results are only going to be as good as the measures we use. Thus, we are strongly trying to encourage the use of some kind of standard THC unit, and we need to have better educated consumers. We are restricted in some of the research we do, as I said, because it is illegal on a federal level. We're playing catch up with the product diversity and the roots of administration. We're playing catch up with the ramifications of the Farm Bill and its loopholes. We're very interested in the policies that are being implemented to promote social equity and the many factors that can affect both the criminal and the non-criminal outcomes. And again, as you saw, despite the fact that many of the reasons why states passed legalization had to do with the disproportionate harm created by prohibition, whether or not they have now gone, whether or not those disparities have gone away is quite questionable from the data that you saw, and we don't have enough good data on that. We know that the U.S. model is one of complete commercialization, but there are many other models for implementing legalization. And one thing that really wasn't part of the report, that was not a focus, we left something out of our statement of work, which is really about the medical effects. And we're very interested in the medical effects of cannabis and cannabinoids. And we don't have that information in most of the health records either. So we have another major gap in our data collection that could really help us better understand what the potential benefits are, what the interactions are with other medications, why people are using cannabinoids or cannabis for these health problems, and what their outcomes are. So my top 3 messages in summary are that if legalization is going to happen, it's best to start from the highest level possible in order to have some broad oversight and some consistency in the regulations. And I think the U.S. is a cautionary tale of how not to do things with no federal oversight. We have all of these different policies and regulations that are being influenced by a variety of stakeholders with different motivations and not always public health motivations. Federal oversight could help establish a broad framework, and I think we'll hear a little bit more from Hanan about Canada, and we already have heard about what's going on there. There are a lot of reasons why this didn't happen in the U.S., but rather than go, since I'm over time already, I'll not discuss them. But one of the corollaries is that we need to be collecting data as early and as comprehensively as possibly before some of these changes go into effect, because after they go into effect, not only are you sort of missing the baseline, but people are collecting more data on cannabis, they're collecting more information, and it may lead to this false belief that so many of these harms have really gone up tremendously when in fact you just weren't measuring what was going on beforehand. I think the other, and again I come back to the fact that there are various regulatory schemes that exist between prohibition and complete commercialization, and anybody that's interested in legalizing should be considering these, in my view, as a person who, not saying that as a representative of the government. I would say to proceed, the second one is proceed cautiously. Regulations can always be loosened, much harder to change them once they've gone into effect. And the third thing is just to expect the unexpected. All of the new products, all of the hemp products, those were not on anybody's radar screen when this started, and yet they are having a tremendous effect. So, thank you.
Thank you, Susan. I'd now like to introduce our final speaker, Hanan Abramovici. And Hanan is the director of the Office of Cannabis Science and Surveillance at Health Canada. Hanan has been involved in numerous Canadian federal government monitoring, surveillance, and research activities on cannabis. And in 2017, he founded the Office of Cannabis Science and Surveillance, the OCSS, at Health Canada. The OCSS provides scientific expertise on a variety of topics related to cannabis to support activities that include research, surveillance, public education and awareness, policy development, and compliance and enforcement actions. Over to you, Hanan.
Good morning, and thanks very much, Elle, for that introduction. It's a pleasure to be here. I think I was asked to kind of provide some perspectives, Canadian perspectives on research, what kind of research we find useful, what the research landscape and surveillance landscape look like in Canada. And maybe before I do that, I'd like to spend a minute or two just to make sure everybody is on the same page about like the framework that we have in Canada on cannabis legalization and regulation. So in Canada, cannabis was legalized on October 17, 2018. And there were two major objectives of the Cannabis Act. One was to protect public health related to cannabis, and the other one was public safety related to cannabis. And there were 7 objectives laid out in the Cannabis Act. And those are to protect the health of young persons by restricting their access to cannabis, protecting young persons and others from inducements to use cannabis, providing for the legal or licit production of cannabis to reduce illicit activities in relation to cannabis, deter illicit activities in relation to cannabis through appropriate sanctions and enforcement measures, reduce the burden on the criminal justice system, provide access to a quality-controlled supply of cannabis for adult use only, and to enhance public awareness on the health risks associated with cannabis use. And in the Cannabis Act, and I think François mentioned it at the start, there was a little paragraph at the end that basically said the government shall do a legislative review of the Cannabis Act within 3 years of the coming into force of the Act, and then within 18 months of that time, a report shall be tabled in the Parliament. And that's what happened, and I think François mentioned it briefly about the legislative review of the Cannabis Act, and that review was completed at the end of March of this year. In the original mandate of legislative review, there was only essentially 3 things that the government had to look at. One was the impact on public health, and in particular on the health and consumption habits of young people with respect to cannabis use, the impact of cannabis use on Indigenous populations and communities, and the impact on the cultivation of cannabis in a dwelling house, in other words, home grow. That mandate was expanded to include a few other things. One was to look at economic, social, and environmental impacts, progress towards providing adults with access to strictly regulated, lower-risk legal cannabis products, progress made in deterring criminal activity and displacing the illicit cannabis market, the impact of legalization and regulation on access to cannabis for medical purposes, and the impact on marginalized communities such as Indigenous people, racialized communities, and others, women who might be at higher risk of harm or face greater barriers to participation in the legal industry. So in the final report, we had a final report of the expert panel on the legislative review. Then we also had one in 2016 that advised the government on how to go about creating a framework for legalizing and regulating cannabis in the first place. So in both of those reports are extremely comprehensive, that took an enormous amount of work, and very thorough. The expert panel that commented on did the legislative review was composed of 5 members of various, covering various topics or various areas of expertise. The legislative review exercise consisted of over 140 engagement sessions and heard from over 600 stakeholders and I think 250 different organizations, including people with lived and living experience. And the panel took an evidence-informed approach, incorporating research findings, statistics, and data, as well as various insights from a lot of different stakeholders and points of view. So just a couple of things. I know I'm kind of spending a lot of time on this, but I think it's important in the context of what the recommendations were for research and surveillance and the type of research and surveillance data that we used or that the panel used to inform its legislative review. So I just wanted to give a little bit of background there. So the panel concluded a few things really high level. One is that they believe that there has been significant progress made on several of the key objectives of the Cannabis Act. Notably, they picked out the establishment of a licensing framework that supports a legal industry, steady progress in shifting adult consumers to the legal cannabis market, adherence to rules on promotion, packaging, and labeling, and a significant reduction on the burden in the justice system. However, despite all of that progress, the panel did note a number of shortcomings or works in progress. One of them is on youth and children. So one thing that they noted was that although cannabis use among children and youth, or youth and young adults, I should say, or specifically youth, really, has not gone up. It hasn't gone down, but it hasn't gone up, and it's still very high, and the panel was quite concerned about that. In young adults and adults, the rate of cannabis use has increased, but it's basically following a trend that existed pre-legalization. The other thing that they noted was a concern around an increase in the number of in the volume and rate of poisonings among young children. So that was concerning to them. Also, they were concerned with high-potency products, noting a shift towards the consumption of higher-potency cannabis products. They were also concerned about impacts on First Nation, Inuit and Métis communities, challenges to the industry faced because of taxes and other regulatory burden. Although the legal market now composes 70 to 80% of essentially the cannabis market, so most consumers are getting their cannabis from the legal cannabis market, but there's still not insignificant amount of consumers purchasing their cannabis from the illegal market. So progress has been made, but it's not 100%. And they were also concerned about access to cannabis for medical purposes. So patients still expressing concern with their ability to access cannabis for medical purposes, whether it's related to cost, access to certain products, guidance from physicians being informed about cannabis for medical purposes, and so on. And also concerned about filling the research gaps. So I think Susan mentioned that despite decades of research on cannabis, there's still lots we don't know. So on the knowledge gaps, I'm getting to it. So one of the things that they noted was that there was information missing on cannabis-related poisonings among children. So although we have some data in Canada that we used to inform the legislative review panel, the gaps that are still missing are trying to understand the sources of the cannabis involved in these poisonings. In many cases, we don't really know where they're coming from, but parents didn't disclose or the physicians didn't put in their records, or simply the system is not really designed to kind of pick out that information from the health administrative data that we have. Similarly with doses, we don't know what doses were involved, what products were used, or even the circumstances around the accidental consumption and poisoning. Another gap that they noted was the amount of cannabis that constitutes a single serving. Susan mentioned, as well as François mentioned, that Canada is working on developing and implementing a standard THC dose unit to guide consumer decision making. Another thing that the panel noted was the impacts and effects of cannabis legalization, specifically high potency and novel cannabis products. They were particularly concerned about that and the impacts on mental health and psychosis and substance use in diverse populations. Another key knowledge gap in Canada, as I'm sure in many other jurisdictions as well, is the health risks associated with the emissions from smoked cannabis products, and there's many different varieties and forms and types of smoked cannabis products. It's not the same dried flower that existed many years ago. There's a lot of industry innovation. Industry is doing a lot of things on dried cannabis, including infused pre-rolls and many other different types of products. We don't know what's in these emissions or their health risks. Similarly with vaping. Impacts of cannabis use on different stages of life. Susan talked about the ABC study, really important study. I think we're all really interested in seeing the type of data that's going to come out of that study. Also the prevalence of people living with cannabis use disorders, different types of interventions and their impacts. And another really important one is trying to understand getting better data from surveys conducted in our various provinces and territories. The federal government, Health Canada, and other partners at the federal level conduct a number of different cannabis surveys. We have the Canadian Cannabis Survey, the Canadian Alcohol and Drugs Survey, the Student Survey, Community Health Survey, and many other surveys. What's really missing is that we don't have a lot of provincial territorial surveys, and that's a key knowledge gap. So, trying to understand what's happening at the individual province territorial level from these different surveys would be helpful. So the panel made 54 recommendations and 11 observations. The recommendations were for the federal government, 11 observations for provinces and territories and others. And some of the things that they wanted us to look at is to identify key research priorities, produce and disseminate clinical guidance on cannabis for medical purposes, continue and even enhance ongoing surveillance and monitoring through various surveys as well as health administrative data, make improvements in our ability to collect data from various sources and disaggregate that data by relevant demographic factors, develop and implement this THC standard unit we've talked about, defining high-potency cannabis products and try to find ways to discourage or temper the use of such products, update our health warning messages, establish and fund a research strategy on cannabis and its effects on Indigenous peoples and communities, and so on. And then in terms of the data that we used that to help inform the work of the legislative review panel, a lot of that data came from all of our surveys that I mentioned a few minutes ago that look at things like prevalence of use, frequency of cannabis use, the types of products used, the sources, their price, risk perception, impacts of public education and awareness, knowledge of the risks of cannabis use, driving under the influence, polysubstance use, and many, many other outcomes. Health administrative data, so emergency department visits, hospitalizations, cannabis use disorder, hyperemesis, psychosis, schizophrenia, and so on. Pharmacovigilance data, so looking at adverse reactions to cannabis, both from the illegal products coming from the illegal market or the legal market. Impacts on the market, so understanding where consumers are getting their cannabis from and how much inroads we're making in displacing the illicit market. Economic data, so looking at prices of various products, product offerings, point of sale data, retail density, and the evolution of the retail space. Public opinion research on cannabis, including understanding qualitatively and quantitatively what people's opinions are on cannabis and using a sex and gender-based analysis plus approach, looking at various different types of groups such as youth, frequent consumers, older adults, and so on. Impacts on the justice system and cannabis-impaired driving. So maybe I'll just stop there because I know we're running late or running short on time. Thanks.
Great, so thank you, Hanan. We're now going to open it up to the audience for a Q&A. We've got just over 10 minutes for this, and so if I could invite you to go to the microphones on 1 and 2, and we'll alternate. But while people are coming to the microphone, I'll take my privilege as chair to start as a question. And it's potentially directed to Hanan or François. What was the international response like to legalization for Canada in those early stages, generally from potentially international agencies such as UNODC, etc.?
Yeah, I can tackle that one really quickly. I would say that a lot of countries are curious and interested about the approach that Canada took. And had a lot of questions for us on how it's going and what our, I guess initially it was like, what is our framework going to look like, and you know what we're planning on doing, and then it was like, how's it going so far? You know, a couple of years in, are you seeing any like crazy things happening, or is there anything really to worry about? And then I would say now it's just more like looking at the legislative review. Oh, this is kind of what you guys found, and this is all the work that still remains to be done. I would just say a lot of interest, a lot of curiosity, and all of that. So yeah, that's impression so far. Thanks.
Thank you so much. Johannes Struhl from Johns Hopkins University. I just wanted to put a plug for medical cannabis research and doing more work in that space. So thank you, Susan, for mentioning that. And we're incredibly grateful for having NIDA funding to develop a medical cannabis patient registry that will provide hopefully a platform for data sharing. So if people are interested, come find me at the conference. We just have a paper out in Nature Medicine that talks about the need for collecting better data in electronic medical records, because I think there's a wealth of data there that we currently don't understand well because cannabis products are so complex. And by using this term cannabis, this broader label, we're really losing a lot of the nuance there that we need. So thank you for a great panel.
Thank you for doing the work.
Hi, Jean-Sébastien Fallu from Université de Montréal. My question is for the whole panels. Hi, François, Beau, and Rosie. In terms of of future research directions. Do you think we should go towards looking more into benefits of use? Who is using non-problematically? Is there any replacement between cannabis and other substances like alcohol or others? Are new users less at-risk users compared to before legalization? Also, maybe the confounders like COVID, I'm not sure you talked about this, or even medical supply, because a lot of people supply their medical cannabis within the recreational market. And what about, maybe you talked about it, but reduced stigma. Stigma is a social determinants of health, whatever some say about it. And I think in terms of equity, we should include reduced stigma. And by the way, I just want to mention we all received a letter for welcoming here, and it was a commitment for DEI and people feeling good from all sorts, of sexual orientations and stuff like that. But what about people with living experience of drug use, and maybe including them in the research?
I think these are excellent points. I think there is a lot of research that's being done on the benefits of cannabis use, but I think one of the ways to get that research in the forefront in terms of evidence and attention goes back to the standardized dose and what is a standardized dose. Because when we talk about alcohol and moderate alcohol consumption, we have a common international idea of what that is and what that's represented based off of a standard drink. And until we establish that standardized dose, and that dose is not necessarily the same as a medical dose. Those can be very different things, but from a benefit of general adult consumption, until we have that measure, I think it's going to be hard to distinguish beneficial use from potentially harmful use. Like anything, it's a function of who's using, in what circumstances, and what is their prior experience. Some of those factors we can get at now, but if we don't know what they're consuming, the healthcare data, administration data, great for poisonings, but we don't know how much caused a poisoning in a youth, in an adult. We need more information in order to be able to delineate good, beneficial from harmful. And I think that research is ongoing right now.
So actually, that's what I was just going to come back to. First of all, thank you for promoting the standard unit. We are really trying to do this everywhere we can. But second of all, the stigma thing I think is really important. It's also really important among women who are pregnant, because we know a lot of them are using substances and they are at risk if they disclose that they are using during their pregnancy. So I think there are a lot of aspects to the stigma that are also really important, and I don't want to keep plugging NIDA, but we and other institutes are also funding a study similar to ABCD, but starting with women who are pregnant and following them and their children for 10 years. And we hope to have about a quarter of the study population, which we imagine to be about 7,000 people, would be women who have used substances during their pregnancy. And so, again, I think it's another thing that we will be starting to get that information. But we've had to go through great lengths to protect them from any sorts of legal repercussions that would happen as a result of their participation in the study. So stigma is very important, too, I think.
Hi. Sorry, I'm a little bit small for the microphone. My name is Eva Havelka. I'm a trainee psychiatrist in Zurich, and I'm working on one of the pilot trials that François touched on, so we actually have a lot of the regulations in place that you recommended. And as the study doctor, one of the things that I'm curious about is how sort of the approachability of physicians in the US and Canada has changed or not changed now that cannabis is legalized, and how it could potentially be improved. And another thing is, I guess, how we can increase knowledge and train physicians to have a better understanding about cannabis, because once somebody has kind of gone over that hurdle and approached their general practitioner about potentially having problematic cannabis use, if they don't have good answers, then that's a limitation.
Thanks for the questions. It's a bit complicated. I'm not involved with doctors prescribing or Actually, in Canada, there's no prescribing of cannabis. It's a document testing that you can use that's delivered by doctors. The reason being that there's no drug identification number in Canada, so it's not a recognized treatment so far. And there are many ways in which this is working, in my understanding of things, but provinces that have set up trainings for doctors in many cases. Sometimes in the industry itself, like the doctors involved with some clinics that are providing training to doctors. I think there's a way to go into adjusting the dosing and all these things. I'm not sure there's been a large progress, largely because it's not recognized as a treatment. So it's kind of I think in the US it's a bit different. There's been maybe the FDA has approved one natural product for some treatments, but in Canada it's not progressing in that way so far. So yeah, the medical practices around this remain a bit, I think, fuzzy from my understanding, but I'm not a specialist.
I would say if you really want to understand how cannabis is being used as good medicine, you should look at Australia and Israel, and perhaps the Netherlands, where there's more federal management of the medical discussion, training of clinicians, monitoring of products, and actual dosing. I think if you look in the US, I won't speak for Canada, first of all, we don't have a singular healthcare system. We have multiple healthcare systems. We have very bipolarized views among the medical profession regarding the therapeutic benefits. And it goes back to a point that was raised already. There isn't a single cannabis product. And so in the US, I think the discussion gets garbled. And I think more of the medicalized countries that have been thinking of it from a therapeutic clinical perspective offer good models for going forward.
Yeah, maybe I can just add a couple of quick notes. I think in Canada, François did mention there's no prescribing of cannabis because it doesn't have a drug identification number. So everything has to go through an authorization, which is basically providing access to cannabis for medical purposes without it being a prescription, without all the things that come with prescribing. I think that if you look at the legislative review report, you'll find maybe some of the answers to some of your questions about what the panel concluded based on their extensive consultations and the data that was provided to them. Essentially in Canada, on the terms of approachability, which was one of your questions, I don't know that the panel necessarily spent a lot of time talking about it, but I would say that not a lot has changed, I'd say, overall in terms of physician comfort with cannabis for medical purposes overall on a large scale. I think what you've seen in Canada is the significant increase in the number of specialized cannabis clinics where physicians specialize in cannabis medicine or cannabis treatment, if you want to call it that. So these are physicians who've taken more training and have more experience with patients. And then what happens is a patient will go to their general practitioner, there'll be a conversation, it'll go down the path of maybe cannabis for medical purposes is an option, and then that physician will refer the patient to that specialized cannabis clinic. So I think that's kind of what's happening on that front. In terms of, I think one of the barriers to cannabis for medical purposes, I'd say overall, is the general lack of research on cannabis for medical purposes. We heard a lot about there's so many different products and there's so many different medical conditions and so many different types of patients. Like, how do you mix and match all of these different things when so little research has been done on, in Canada we have like hundreds and hundreds of different products. It's very difficult, I would say nearly impossible, to do medical research on all of these different products for all of the different medical conditions. So a lot of the practice is a bit of trial and error, right? You'll try this product, the clinic will start on this product, then we'll try that product until they find the right one for the patient and their medical condition. So I think one of the things that comes out in the report is the lack of research on cannabis for medical purposes, the need to provide more clinical guidance. But you can't really do that unless you have data or research to do that. So those things are kind of intertwined. I'll just stop there because we're running short on time.
Thank you.
We have time for one quick question.
Thank you. Wonderful, Barbara and Brookings. Beau and Rosalie, wonderful to see you. I wondered if you looked at the Commission's report on the role of Chinese organized crime in the US illegal cannabis market, which is arguably the most fascinating development after the extent of illegalization. All of a sudden, very powerful, not well-established type of organized crime is making this major impact and connecting to a variety of illegal economies, including pot. And for our Canadian colleagues, can you tell us anything about the role of organized crime in Vancouver, British Columbia, or Canada more broadly in the existing cannabis market there?
That's an excellent question. And I wish in the statement of task we would have been able to explore organized crime a bit more. As far as we got was just focusing on the production of cannabis illegally in places that have and have not legalized. And it's still happening. We have no idea if it's increasing or decreasing on net. And the other thing that I think when we talk about the illegal market is important is to make a distinction between two different kind of, two categories. One is what share of people who are using cannabis in a state, or what share of them are getting their cannabis from the state legal markets? And we see that is increasing over time in places, but it does take time. And then the second part is what's happening with illegal production. Because we still know a lot of it's happening. There's still a fair amount in California and other places. But no, we didn't look at the organized crime connection.
I don't have a sense of the overall picture of organized crime in Canada, but I think in the expert panel review there was an issue that was raised around a provision in our medical system which allows one person to have a designated producer, and so the idea is that some designated producers would have many patients or designated patients, and would use these licenses to shield themselves from police view. And this actually I was participating in a meeting organized by the RCMP in Montreal when I worked at the Public Health Institute in Quebec, and this issue was described all day by police forces that had problems investigating that. And I think it was outlined also in the review, the legislative review. At the SSDP, there was a presenter also from the African continent. I can't remember which country, that came in and said they received a lot of diverted products. I don't think it was from the legal sources. I think it was from the illegal producers in Canada that were coming to some countries in Africa. But beyond that, I'm not in enforcement. I work mostly in public health, so I'm limited in what I can say with regards to that.
But just one final point. Why we didn't focus specifically on organized crime, and one of the takeaways is you have to be thoughtful about enforcement. As I said, when you're spending that time thinking about licensing regimes, if that's the pathway you're going to go down, you also need to think about what you're going to do on enforcement. And especially if it's lax, what are you going to do if organized crime gets more involved? So I definitely think that needs to be part of the thought process.
Yeah, if I can just add to it. So in my conversation with US law enforcement, there is tremendous concern about the expansion of Chinese organized crime, also very powerful in Canada, in Vancouver, in the pod industry, but their sense is that because of federal guidance not to enforce the illegal cannabis market for other reasons like public health reasons, the only way they can be going after Chinese organized crime is through a money laundering aspect. So as long as they can identify a money laundering component, they can go after the illegal pot. But nonetheless, it raises the complexity and really the stunning development. You wouldn't expect a very powerful newish organized crime entity to move into a market that is being very heavily legalized. And yet, thank you.
That's a wrap. Thank you all to our speakers and the audience for coming. I believe it's now lunch.